Hello everyone, today I would like to talk about a case study which the topic is CA rectum. First, let's talk about the background information of the case. The patient is a 52 years old man who diagnosed with stage 3B squamous cell carcinoma of the middle third of rectum. Before talking the details of the case, I would like to introduce the background information of CA rectum. According to the data collected from HA in 2016, colorectal cancer in Hong Kong is the #1 cancer. Incidence rate of men is higher than that of women. Also, it is the second leading cause of cancer death, and the age of onset is over 50 years old. In the case, it does not mention any medical history of the patient. Thus, we cannot know which factors that risk to have CA rectum. And for SCC rectum, risk factors are not exactly known. There are some possible risk factors, which include age over 50, personal or family history of cancer of the colon or rectum, history of polyps in the colon, and certain hereditary conditions. And there are some research provide the strongest association evidence that the history of ulcerative colitis or Crohn's disease can increase the risk of having SCC rectum. On the other hand, there are a few histological types of CA rectum, which include adenocarcinoma, which is the most common one, squamous cell carcinoma, medullary carcinoma, small cell carcinoma, lymphoma, and sarcoma. During this moment, I want to give a comparison between SCC and adenocarcinoma of rectum first. SCC is a female predominant case, while adenocarcinoma is male predominant. Then the treatment guideline. For SCC case, it treats with concurrent chemo-RT first, then followed by surgery, while adenocarcinoma case is surgery first, followed by chemo-RT. Although SCC is histologically similar to anal SCC and anatomically identical to rectal adenocarcinoma, the treatment guideline is similar to SCC anal case due to the cell type. Also, surgery improved the overall survival in adenocarcinoma, and RT improved overall survival in SCC, and the prognosis of SCC is worse than adenocarcinoma. Here shows the proposed treatment algorithm for SCC rectum case, which is very similar to SCC anal case. Okay, let's start talking about the case. Before diagnosing the disease, the patient complained of bleeding per rectum, pain during defecation, and constipation of 3 months. Change in bowel habits and weight loss are proved, which are also common for SCC case. And there are some possible signs and symptoms: blood in stool, diarrhea, frequent gas pain, bloating, and fullness, feeling very tired, and vomiting. This is the simplified treatment timeline once the patient diagnosed with SCC rectum. After diagnosis, he treated with concurrent chemo-RT. 6 months after the completion of chemo-RT, he confirmed a recurrent SCC, and he undergone the low anterior resection of the rectum. 15 months after the surgery, he confirmed a recurrency with multiple liver metastases, and he was given palliative chemotherapy. And I will talk about the details part of this case. After presenting the signs and symptoms, he undergoes some examination, and there are some findings. The digital rectal exam showed a growth was felt in the rectum starting 7 cm from the anal verge with prerectal node. The coloscopy showed a proliferative growth in the middle third of rectum. And finally, the biopsy confirmed the poorly differentiated SCC of the rectum. Then he undergoes the concurrent chemo-RT. The case report only mentioned he undergoes 50.4 grade external beam RT and 2 cycles of 5-FU and mitomycin C. Thus, this is the RT technique that I expected. I think this is the radical treatment, which aims to cure the cancer by treating the primary tumor and nearby lymph node. And this is the most conventional treatment that is used. This is a 2-phase treatment. The patient is head first prone with belly button and fully bladder. The technique is 3D CRT. We treat with 1 posterior field and 1 lateral opposing field, that with wedge or using fill-in field. and phase 1 is given 1.8 gray per fraction to 100% isodose level, 5 fraction per week times 25 fraction to total 45 gray, then changed to phase 2. Phase 2 is given 1.8 gray per fraction to 100% isodose, 5 fraction per week times 3 fraction to total 5.4 gray, then stop. Those DRR at Y side shows the field coverage of the treatment. 4 weeks after completion of chemo-RT, the patient undergoes the follow-up. The CT and sigmoidoscopy showed the complete clinical regression of the primary tumor and the perirectal lobe, and the biopsy showed no evidence of residual malignancy. Later, the patient was advised the surgery, but in view of the complete response, he declined. Hence, he was advised for close surveillance, and it was decided to do a PET-CT scan 12 weeks after the completion of chemo-RT, but the patient deferred a follow-up and presented 5 months later with complaints of pain during defecation and backage. The biopsy confirmed a recurrent SCC, and PET-CT showed a metabolically active lesion in the rectum with a standardized uptake value of 10.5 and no other signs of disease. Then he undergone the low anterior resection of the rectum. Low anterior resection is a surgery that the cancer and margin of normal tissue on each side of the tumor are removed, along with nearby lymph node, fatty and fibrous tissue around the rectum. Then the colon is reattached to the rectum that is remaining. This way, a permanent colostomy will not be necessary. The biopsy is taken during the surgery and it showed a residual SCC in the rectum with stage YPT3 and 0 with a least circumferential margin of 1 mm posteriorly, and he was kept on regular follow-up after surgery. 15 months after the surgery, the PET-CT confirmed a local recurrence and also present of multiple liver metastases. Thus, the patient was given palliative chemotherapy, and he is alive with the disease nearly 3 years after the first diagnosis. Now, I want to suggest other RT techniques that can use it. First, using IMRT to replace 3D CRT. To look at the CT plane and DVH, 7-fuse IMRT can provide superior target coverage, homogeneity, and conformity than 3D CRT. Also, OARs are another concern of RT. For rectum case, femoral head, bladder, and small bile are the mainly concerned. The DVH showed the OAR sparing of IMRT also better than 3D CRT, especially small bile, which can reduce the active toxicity due to the irradiation to bile. Another technique is using brachytherapy. There are some research claim that endorectal brachytherapy can be administered either alone or as a boost after external beam RT. Look at the DVH. It provides more favorable toxicity and lower the 5-year local recurrence than those of the external beam RT. It achieves a high dose rate with Irradium-192. The source is introduced through catheters fitted into an endorectal applicator, which is then inserted into the rectum, just like the photo shows on left-hand corner. The prescription is given 6.5 gray per fraction to CTV, 5 fraction per week times 4 fractions, to total 26 gray, then stop. But the main concern is the side effect, which would cause prostatitis and skin reaction. As SCC rectum is a rare case, there do not have too much research about other treatment modality. However, over recent years, there has been an increasing use of molecular target therapies in solid and hematological malignancy. Also, immunotherapy in the form of tumor vaccines, adoptive T-cell therapy, and immune checkpoint inhibitors has become one of the treatment modality. However, there is currently no literature on this modality in rectal SCC. It becomes a major focus for research in the treatment of cancer, with translated clinical success in specific tumor types, and the early results in other tumors hold promise for a possible role in future treatment, particularly in the colons of patients with persistent, recurrent, or metastatic rectal SCC. In the case, it does not mention the side effects of the patient, thus the expected side effects are cystitis, processes, diarrhea, fatigue, and skin reaction. Although the case has already mentioned the follow-up of the patient, I would like to introduce some common exams that would take in the follow-up appointment. First, patients should go to all follow-up appointments. During the visit, the doctor will ask if you are having any problems and may do exams to look for treatment side effects. The patient will undergo endoscopic examination to rule out any local recurrence or new primary lesions. Also, patients should have imaging of the liver, either by CT or ultrasound scanning, as liver is the common site to spread. Last but not least, there are the expected patient care, which are plenty of rest. If diarrhea presents, avoid eating vegetable, and the clothes mainly made from cotton to avoid serious skin reaction. Finally, is the expected prognosis. The favorable prognosis factors include younger age, tumor size is smaller or equal to 3.9 cm, and localized stage. And for this case, the overall 5-year survival for rectal SCC is 48.9%, and the 5-year survival rate for stage 3 SCC rectum is 33%, and after metastasis is 20.8%. And this is the reference, and this is the end of my presentation. Thank you.